Hello, welcome to the fifth module of the series COVID-19 and GI Tumors Update 1. Today's session is approved for 0.25 hours of CME, CNE, CPE, and APA credit. The series is provided by North American Center for Continuing Medical Education. My name is Axel Gothi. I'll be the moderator for today's program. I am the Director of GI Oncology Research at the West Cancer Center and Research Institute in Germantown, Tennessee. I'm joined by Dr. Kathy Eng at Vanderbilt Ingram Cancer Center just down the road in Nashville, Tennessee. She's the co-leader of the Gastrointestinal Cancer Research Program. Welcome, Kathy.
Thank you for having me.
So we'll take the next 10 to 15 minutes to discuss whether patients with coronavirus infected, and GI cancers, whether they are at high risk for complications if they test positive, whether we see some differences in outcome based on age and kind of comorbidities, perhaps race, ethnic identification, and also how we've addressed, our cancer care and if we changed the cancer care in the time of COVID-19, which is something that has really changed the way I personally treat patients and follow patients more than anything, Kathy, can you highlight what are if you had to bring down, let's say, the 5 critical points that have changed in the last 6 months, for you, how you take care of patients, what's different for GI malignancies right now?
I would say what's different for GI malignancies is, number one, we are definitely trying to accommodate our patients a lot better in the sense that obviously our surveillance patients, we aren't requiring them to come in. We would prefer for them to be doing telemedicine. And if they need a scan, we arrange for it to be conducted locally, and then we will submit it to be read at our institution. For patients on treatment, if they can be converted to an oral chemotherapy regimen, for instance, 5-FU, infusional 5-FU versus a LOTA, if that's a possibility, we do try to incorporate that. I think that if we're going to consider clinical trials, we're also looking more at the regimens that are more inclusive of oral chemotherapy rather than the more complicated regimens that are mostly IV. And especially if you're talking about a trial that's phase 2 in development, and you obviously don't know which regimen is better than the other, it's very reasonable. We're doing a lot more telemedicine, as you can guess, and depending upon the patient population, we're not. We may have them come in, we may not have them come in. It just depends. We've been getting their blood work done locally. We're associated with Walgreens, so we do it at the local Walgreens, and then it goes immediately into our system. So whatever we can do as a precautionary measure for our patients, we are doing. We are obviously omitting bolus 5-FU leucovorin, which can cause increased myelosuppression, as you know. And then for patients even on the FOLFOXIRI regimen, instead of waiting after the first cycle to see if they're neutropenic, I have to say we are empirically getting them started on Neupogen or Neulasta, depending upon their insurance provider, as a safety net. We want to ensure the safety of our patients, and we're being just as cautious as possible, and really discussing with the patient and making sure they communicate with us a lot more so. And I think it's because of telemedicine, they're aware that they can reach us if needed, and we can look at them and see how they're doing.
Yeah, I think there's some low-hanging fruit that you already mentioned where we make changes which we should probably keep forever. Mainly telemedicine is, like checking on patients, toxicity, after 1 week, when you, or even 2 weeks, when you just want to see how patients are doing, they don't have to come in. Deleting bolus 5-FU from FOLFOX, that's long overdue.
Yes.
Port flushes, do you really need to do port flushes every 4 or 6 weeks? Their data, you can probably stretch it out,
Yeah, I historically have always done it around, 8 to 10 weeks already. So, and knock on wood, so far so good after all these years. But because I always thought it was a bit of an inconvenience for patients.
Right, and I completely agree. And in particular, patients who want to port in for some time after completion of adjuvant therapy, for instance. Then I think we went a little bit overboard at some point in how we kind of keep our patients on surveillance, how often we did blood draws, they came in for scans and whatever. And really critical value-based assessment shows, does it really help us to detect things recurrence earlier? What does it mean if we detect it a month or 2 months earlier for the overall outcome for patients? So I think there are certain things which we really should continue to, change, once COVID epidemic pandemic is over.
I fully agree with you. I think, I mean, COVID obviously was something completely unexpected for many of us, but it also made us think about how we need to change our approach to patients. And I think, you know, I actually had another discussion with another individual about this post-COVID era and how we're going to potentially change medicine. And they were very focused on it just being more of a COVID issue. And I don't think it's a COVID issue. I think it's more about, okay, these are the things that we were able to accomplish during COVID and how can we incorporate them in the future? Because they obviously, not all of it, but some of it does have benefit, and it's really modernizing our approach to our patients and their care.
Yeah, it's a value assessment. What really works? Because what we try to do is not missing anything right now, really ensuring that patients will still get best care. So we're prioritizing. We're really putting up, you know, what is important. And I know Deb Schrack had an interesting article in JAMA, you know, prioritizing, you know, cancer care in the time of COVID. So a lot of this actually it's really common sense, you know, what is important, curative versus palliative approaches, etc. I think, you know, we're in the process of active learning right now. So one of the things we want to talk about is also, you know, when patients are cancer patients, when they're positive, do you see more complication? Have you had patients succumb to the disease, have had severe complications? And do you think there is a certain patient population that is at specific risk in GI malignancies?
So I have to say I've been very fortunate. None of my patients have been symptomatically impacted by COVID. I've had some patients that have tested positive, but were completely asymptomatic even though they were in chemotherapy. I had one patient on FOLFOXIRI and she had no symptoms. So I think it just varies. Obviously, I think an elderly patient, I think it's been shown that obviously patients of, you know, African-American patients, Latino patients, our underserved patient population as well, they're going to be at higher risk because I think in all fairness, they may not have the means to necessarily show up for their appointments, or they may not contact you, or they may still be trying to work because they have to. So I think that sometimes that patient population obviously it's going to be at higher risk, obviously our elderly patient population, and those also I think the literature shows those with hypertension, that's also an increased patient population. It's going to be very different from your lung cancer patient population versus our GI patient population. I think it just depends also upon the regimen. So, you know, FOLFOXIRI puts you more at risk for myelosuppression or neutropenia, and that may be a greater risk factor than somebody that's just on, you know, 5-FU.
Yeah, I had in a similar situation as you. Have been very fortunate, you know, and in spite of the fact that we have a much higher percentage of African American patients in the Memphis area than in Nashville, that's really a very different world in this regard. I remember one patient who was on a kind of conversion therapy for liver metastasis and colon cancer, was on FOLFOX, and she tested positive for coronavirus, and we stopped therapy, and she was angry because she had no symptoms at all, and she said, "I got cancer. Why do you stop therapy? Because it's much more threatening to me than this asymptomatic virus that was really interesting." But what you said is also, the epidemic right now has really exposed some of the flaws of our society in the sense, you know, it said not everyone has healthcare, and if they have healthcare, they keep it because they get it through their employer. So they want to work, and when they have symptoms, they still go to work. You know, they can't stay home. There's not this immediate access to unemployment coverage, etc. And so it's really, we're not equipped as well as other countries to deal with this overall. But that's again a political statement, which is very difficult. So we do the same thing. We prophylactically give growth factors, you know, as with the, you know, even with kind of the chemotherapy doublet, when we see the ANC goes down, you know, we are trigger happy to do that. And in discussion with insurance companies, normally they approve that. I mean, there's really no, beyond the NCCN guidelines, which also have been kind of modified to allow us to use growth factors in a lower risk of febrile neutropenia situation. We switch, again, we've put a lot of patients on oral therapies, and probably pulled the trigger toward maintenance therapy earlier. You know, do you really need to do 8 cycles, or can you go after 6, you know? So again, a lot is common sense that we're doing. And I still believe one of the most important things is not to compromise the efficacy of our treatments for our patients, because they deserve good treatment. Yeah.
Fully agree with you. Fully agree with you.
So I've personally not yet identified in GI cancers this one patient population at a very high risk, independent of the treatment. You know, but I could imagine that patients who have, let's say, a lot of weight loss, cachexia, or cancers where you have a lot of, let's say, thromboembolic complications, DVTs, like pancreas cancer, for instance, that those are particular risks, especially since we know that COVID can actually lead to this hypercoagulability, you know, which can be a contributing factor to morbidity and mortality.
Right. I mean, I haven't done it, but it makes you almost think, well, should you start, you know, providing them prophylactic,
anticoagulation.
You know, yeah, anticoagulation, just because of that possibility for your patient.
Yeah, I completely agree. So in the end, you know, we currently learning, and I think, you know, the discussions we have, including the, you know, last week's discussion with Dr. Alberto Sobrero from Italy, help us really identify this as a global problem. I would really love us to get together as a global community, learn from each other, learn from experience in China, learn from experience actually right now in Brazil. Our colleagues in Brazil, they get overwhelmed with cases. Learn from New York, how was cancer care delivered in New York without compromising outcomes, and identify patients who are at higher risk for complications.
Definitely.
So definitely an educational need. Okay, so let me conclude. Thank you for joining us for the program today. If you have any questions, please submit them in the Submit a Question tab located on the right-hand navigation bar. One of our expert faculty will respond to your query. To receive your continuing education credit for today's program, please complete the evaluation located on the right navigation bar. You will then be able to download or print your certificate. And please join us next week when we launch the final module in the 6-week series, COVID-19 and GI Tumors Update 2. Thank you again for joining. Thank you, Kathy, for being part of this.
Thank you so much. My pleasure.